Hi, this is Dr. Wendie Berg. I am a diagnostic radiologist specializing in breast imaging, and I'm based currently in Lutherville, Maryland, and soon to be at University of Pittsburgh. I've worked with PEM technology for approximately 18 years now, since the very beginning, and it's very exciting for me to be able to share with you our clinical results, which were published in Radiology in November 2010. The objectives of this session are to discuss the clinical indications for positron emission mammography as well as positron emission mammography guided biopsy. We're going to delve into details of the performance characteristics of PEM, specifically its sensitivity, specificity, and PPV of biopsies that are performed based on PEM findings. And this, again, is based on a comparison study with MRI, and I'll get into more details of our study. In general, molecular imaging of cancer is indicated for initial staging of cancer, for predicting and monitoring response to treatment, and to distinguish scar from recurrent tumor. I'm not going to be discussing that latter application. For the work that I'm going to be discussing today, fluorodeoxyglucose, or FDG, has been used as the radiotracer. This is an analog of glucose, which is taken up by metabolically active lesions, including breast cancer. When we talk about staging breast cancer, there are several issues to consider. The first and foremost is evaluating the ipsilateral breast with the known cancer, looking at the size and extent of tumor, and looking for additional foci of tumor, which could affect pre-surgical planning. We're also going to briefly touch on the contralateral breast. In general, we also are interested in node status, especially the axillary lymph node status. However, that is mostly a surgical problem, so that I'm not going to be discussing that today. And of course, if patients have stage 2 or more advanced disease, it is common to do whole body staging prior to treatment. But again, that's not an issue for discussion today. Response to treatment, and especially chemotherapy given prior to surgery, is another area of active investigation that we'll touch on towards the end of the presentation. When we talk about ipsilateral disease extent, we're really talking not only about size of the cancer, but also these additional foci, which would either make the disease multifocal, where they're separate foci within the same quadrant, or within 4 to 5 centimeters of the index lesion. This is also sometimes defined as multiple tumors along the same ductal system. Multicentric disease is defined as separate foci in different quadrants, or at least 4 or 5 centimeters apart. Here's a nice example of a PEM image of a patient with a newly diagnosed cancer in the retroareolar region. And in her case, in addition to the known cancer, we can also see multiple additional areas of intense tracer uptake in a segmental distribution. And this reflects the underlying extensive DCIS component to her disease, an extensive intraductal component. She also had a multicentric focus in the opposite quadrant of her breast, and this was very extensive disease, confirmed nicely in PEM, and she then underwent appropriate mastectomy. Additional foci of tumor are quite common. There's a nice review of this issue in Laura Lieberman's paper, but from the pathology literature, we know that at least 48% of the time there is additional tumor found if we look hard enough with detailed histopathologic sectioning of a mastectomy where the patient was thought to have just a single focus of cancer mammographically and clinically. We also know that MRI can often show us such additional disease, and in her series, 27% of women had additional foci by MRI. Similar results have been seen in many other studies as well. There's a nice meta-analysis of this issue looking at the impact of MRI on surgical planning. Nemat Husami and colleagues published in 2008. And across 19 different studies of MRI in the pre-surgical breast, additional foci of disease were identified in 16% of women, with a PPV of MRI-guided prompted biopsy of 66%. And overall, about 20% of patients had a change in their surgical management, with 8% having conversion from wide local excision to mastectomy, and another 11% having wider excision than originally planned for their lumpectomy surgery. But importantly, there was an inappropriate mastectomy performed in approximately 1% of patients and excessively wide excision in about 5.5% of patients. And that really is a harm, then, of doing that initial MRI. It's with that in mind that we turn our attention now to positron emission mammography. PEM is a form of PET imaging which uses a dedicated high-resolution device with field of view of 23 by 17 centimeter. As I mentioned, we use glucose for the radioactive tracer analogous to glucose for this study, and specifically a 10 millicurie dose of FDG. The patients need to be fasting for at least 4 and preferably 6 hours prior to injection, and their blood glucose must be less than 140 milligrams per deciliter. We image typically 45 to 60 minutes after injection. This allows clearance of the tracer from the bloodstream and uptake by the tumor. Here is the image showing the PEM imaging device and the patient getting ready to be positioned. You can see that the positioning can be very similar to mammography. We use 10 minutes per view for this study, although shorter acquisitions may be possible. We also use gentle compression to stabilize the breast. It's not nearly as tight as mammography. The patients are very comfortable. And typically we'll obtain, of course, the routine craniocaudal and MLO views, just as in mammography. And we were able to obtain any additional mammographic-type positions as needed to cover the entirety of the breast or the axillary tail region as needed. PEM is much higher resolution than whole-body PET imaging. We see a spatial resolution of about 2 millimeter with PEM compared to 6 to 7 millimeter with whole-body PET. The radiation dose from a 10 millicurie dose of FDG is to the whole body, and it's on the order of 6 to 7 millisieverts. This is comparable to a chest, abdomen, or pelvic CT, and I refer you to a detailed article by Ed Hendrick on this subject. This is certainly a reasonable radiation dose for staging in a patient with cancer. However, this is certainly far too great a radiation dose to be used for screening. Here is a patient who has a known cancer in the retroareolar region of her breast, fairly poorly seen on mammography. With PEM, we obtained 12-slice tomographic reconstruction, and this is the only currently molecular imaging technique which provides us with tomographic reconstruction, which really gives exquisite detail. And here's her known cancer in the subareolar region, as well as additional segmental disease. And she, again, needed to have mastectomy, and this is very nicely depicted by the PEM imaging. Even DCIS is well shown on PEM, and here's a patient who had a palpable abnormality, and you could see very nicely these multiple foci of DCIS. PEM is, of course, metabolic imaging rather than anatomic, so that in this particular patient who had a cancer in the right breast and a fibroadenoma in the left breast, only the cancer shows uptake, and this was an invasive lobular cancer in this case. We had published in 2006 initial experience with PEM, wherein we had 77 women with 92 suspicious lesions, some of which had been previously biopsied and others of which were going to be biopsied. And we found overall very high sensitivity of PEM of 90% and a very high specificity and PPV as well of 86 and 88% respectively. It's that high PPV of biopsy that really intrigued us because we felt that it would be less likely than MRI to prompt unnecessary biopsies and that this could be helpful in surgical planning. Importantly, we also had 3 patients in that early study where cancers were seen only on PEM, and this prompted the development of PEM-guided biopsy, and I'll talk more about that. And importantly, in that early work, we found that even DCIS was well seen. 91% of DCIS was shown, and small cancers as well were readily depicted with PEM, and this was all very encouraging early work. PEM is not limited by the presence of implants, although we did exclude them from this multi-center study that I'll be discussing. And here you can nicely see this known cancer as well as an unsuspected multicentric focus in this patient. We also saw reduced false positives in our early work. As I mentioned, that high PPV and high specificity were very important. This was 12% benign lesions that were suspicious on PEM compared to 51% on conventional mammographic and sonographic imaging. Although we do see uptake of FDG in some, especially metabolically active fibroadenomas, papillomas, and fat necrosis, as well as atypical ductal hyperplasia and LCIS, and this is important to keep in mind. So to get into the details of our study, we enrolled 472 women with newly diagnosed breast cancer at 6 sites. This is an IRB-approved and HIPAA-compliant study. Women had to be a candidate for lumpectomy surgery, and we had them have both a PEM and MRI examination in randomized order, and these studies were independently interpreted. Women agreed to undergo additional biopsies if needed. Here's an example of a participant who had dense breast mammographically. Her known cancer was seen as an asymmetry with associated calcifications, also evident sonographically. This is a high-grade invasive and intraductal carcinoma. On MRI, you could see the known cancer, but there were multiple additional suspicious areas in both breasts on the MRI, which prompted multiple additional biopsies of both breasts, which were all benign. The PEM nicely showed the known cancer and some satellite DCIS foci, but did not have any false positive areas of uptake. And this is just representative of the types of images that we obtained. In fact, this patient also had whole-body PET CT, and you could not see those additional foci of disease that we saw so nicely on PEM. And this is just, again, to show the much higher detail that we get with PEM compared to PET CT or whole-body PET. Overall, in the main protocol, we had 388 women who completed the study with analyzable results. Importantly, the median estimated tumor size was only 1.5 centimeters, so these were small cancers. And 82 of the women, or 21%, had additional foci of ipsilateral cancer seen on study imaging or surgery. And those additional foci had a median size of only 0.5 centimeters, so very small. Again, the patients had to be candidates for lumpectomy surgery, so they had to have a diagnosis of either invasive or intraductal carcinoma prior to study entry by core biopsy. On the recommendation of a breast surgeon, they were considered candidates for breast-conserving surgery with tumor confined to one quadrant. The investigators had all met special requirements. They all had to be breast imaging radiologists who had experience with mammography and met MQSA requirements. They also had to have experience reading breast MRI studies and have availability of MRI-guided biopsy. We had a specific 2-hour training module, which was a self-paced PowerPoint presentation, and included details of how to review the images, how to draw a region of interest, to quantitate the uptake of FDG in the tumor and the background, and details of feature analysis, which are analogous to the BI-RADS for MRI. That material is in press at AJR at this time. There were specific quiz cases they were also required to complete. And interestingly, we found very good success with learning PEM, even though the vast majority of our investigators had not seen any PEM images prior to the study. And these are just AUC curves showing that we had 0.95 for the PEM quiz compared to 0.8 for the MRI quiz. And this just, again, reflects the fact that it's very easy to learn. For analysis, it's important to note that we did not include the known cancer. We obviously know about that cancer, so counting it as seen or not seen did not seem to be something that we really were that interested in, and this is much stricter in terms of our analysis than most of the prior MRI work. And I would just alert you to that because the overall sensitivity that we found for MRI in our series is less than you might expect from prior literature. We did use an expanded BI-RADS type scale for our assessments and separated recommendations from the assessment categories. Positive in our study was a BI-RADS 4 or higher score, or BI-RADS 3 with recommendation for biopsy. Here is another patient in the study who was known to have this palpable cancer, again in the retroareolar region, had an unsuspected additional focus of tumor here. This was also seen on MRI, and this is multicentric grade 3 invasive ductal cancer. She also had a small focus at the nipple, and we can see uptake in the normal nipple on both PEM and MRI, and this can be a little bit difficult to interpret at times. Here is another patient who had pleomorphic calcifications due to DCIS over a 3-centimeter segment mammographically, and on both PEM and MRI, she had much more extensive segmental disease over about a 6-centimeter area, and that was, again, needing mastectomy. Interestingly, we found that PEM and MRI were complementary to each other. So they both saw cancer. Overall, 34% of the additional foci of cancer were seen on both PEM and MRI. 26% only on MRI, and 17% only on PEM. Interestingly and importantly, there were actually 7 women who had additional tumor foci only seen because the investigators specifically reviewed their patients' mammograms at the time of study entry. This underscores the importance of the involvement of breast imagers in the interpretation of PEM imaging. If we look at sensitivity by modality, overall sensitivity for additional foci was 60% for MRI, which is obviously a little bit on the low side, but again reflects the fact that we're only counting additional lesions. And this is not different at the breast level from PEM at 51%, although at the lesion level, PEM was slightly less sensitive, very slightly less than MRI. Again, the two were complementary, so that adding them together, we had a sensitivity of 74%, which was more than MRI alone. And if we added conventional imaging review, that increased to 83%, although there were still, importantly, women who did not have their additional disease seen, but even after the combination of all 3 imaging modalities. Specificity was, we expected to be higher by PEM than MRI, and in fact it was, 91.2% compared to 86.3% by MRI. But because of the very slightly lower sensitivity of PEM, the overall accuracy was the same for any given approach of imaging test, either alone or in combination. So there are some trade-offs involved. Here is an example of an MRI that was not at all helpful. This patient had a known right breast cancer, and it was not seen. I think this is a little clip artifact. Here we have a false positive focus of enhancement on the left side, but her PEM correctly showed the known invasive lobular cancer, no additional foci, and no suspicious findings in the contralateral breast. So this is a nice example of how PEM can be easier than MRI and more helpful. In terms of the biopsies that were prompted by the different modalities, overall PPV of PEM was 55%, which was significantly higher than the 41% by MRI. You can see there were many more women who had to have a biopsy because of the MRI, and that's also important to consider. However, none of these modalities had anywhere near 100% PPV, which underscores, again, the importance of having the availability of MRI-guided or PEM-guided biopsy at your facility. And here I want to walk you through an example of a PEM-guided biopsy. Here's a patient from our facility who had an 11-millimeter mixed invasive ductal and lobular cancer known pre-study entry. And on the PEM, here's her known cancer, and there was a second suspicious lesion about 4 or 5 centimeters anterior to that, which was also evident on MRI. But it was very subtle on the MRI, and we decided to do a PEM-guided biopsy. And here are the images from the procedure. So first we do we immobilize the breast, very similar to an MRI-guided biopsy, where the patient is in compression, and then there's a grid placed. We obtain the image to show the cancer, and this can be a relatively shorter image, especially once we know where we are interested in. And we then, like with MRI, identify where within these grids we need to localize the lesion. We clean the skin, numb the skin, and then we place a trocar coaxial technique, and then we are able to use a line source that's radioactive through that trocar to confirm that our needle is right next to the lesion. Certainly we want to be within 4 millimeters, as is indicated with MRI biopsies. And then nicely, and unlike MRI, it's quite easy to demonstrate that, in fact, the lesion has been removed. So here's just a quick 2-minute image obtained at the end of the procedure showing removal of the hot spot. We, of course, place a clip, just as we do for MRI-guided biopsies, to confirm, to facilitate subsequent localization. And we'll do a post-procedure mammogram as well. And again, unlike MRI, we're able to do specimen imaging and demonstrate the hot spots within the pieces of tissue. We can separate those into a different cassette for the pathologist so that they know exactly what we're interested in and direct their attention to it. And this was the second 5-millimeter invasive lobular cancer in this patient who then had mastectomy. In terms of overall surgical planning of the 388 participants, overall 16% had an appropriate change in their surgical management because of the MRI findings, 11% based on PEM, And in fact, MRI was significantly better at showing the overall disease extent than PEM, although again, they were complementary, and the two together were better than MRI alone. There were 98 women who had a mastectomy, 56 of whom needed a mastectomy based on disease extent. And again, MRI was more likely to have successfully depicted the full extent of tumor. PEM was more likely to underestimate disease, whereas MRI was more likely to overestimate disease. And in fact, again, there were some that weren't recognized by either as having more extensive tumor. Wider local excision was essentially equivalent performance with both PEM and MRI. I also want to mention the contralateral breast. We know from the MRI literature that about 3 to 6% of women will have unsuspected contralateral disease seen at MRI or MRI and ultrasound, and this is in addition to the 1 to 2% of women who have contralateral cancer detected mammographically or clinically prior to the MRI. So it is important whenever we talk about preoperative imaging that we do a bilateral exam. Here is a patient who has a known cancer in the left breast, nicely seen by PEM, and here her unsuspected right breast cancer was also very nicely seen on PEM. Overall, we had 4% of our patients who had contralateral breast cancer identified after study entry. 87% were seen on MRI. Interestingly, the PEM seemed to be a little more problematic for investigators, probably because their attention was focused on the ipsilateral breast. And there was also a tendency to downplay findings in the contralateral breast, so that when we reviewed these studies later, we found a pretty good performance of 73%. But the initial interpretation at the site level was only 20% of these considered suspicious, and another 20% were considered probably benign. Interestingly, another 20% were seen in retrospect when the investigators looked side by side with the PEM and MRI. So the findings were there, but this was a matter of education of the investigators that was needed. And importantly, we also did not have PEM-guided biopsy available at the onset of the study. And even midway through the trial, only 2 of our centers actually could do PEM-guided biopsy. We feel that there was a tendency to downplay additional findings in that contralateral breast initially. And in fact, that probably benign assessment is something that we think we want to discourage from use on PEM, because we found 3 of 22 lesions that were described as probably benign, or 14%, were cancer. And that's far greater than the 2% rate that we expect from mammography or ultrasound. So again, I think because lesions that show uptake of FDG are much more likely to be cancer, we really don't want to call them probably benign if we see them on PEM. The only time a benign assessment would be reasonable for a hot spot on PEM is if we know that this is a lesion that's already been biopsied and it's a fibroadenoma, or it's clearly fat necrosis based on mammography and other findings, those sorts of things. But generally, if a lesion is seen and shows uptake of FDG, it should be viewed as suspicious. Here's just an example from the quiz set of cases of a focal area of relatively mild uptake of FDG, but this was, in fact, a 5-millimeter invasive ductal cancer. And again, a number of the investigators called this probably benign, which isn't very useful, and doing follow-up PEM studies, again, may not be the most optimal thing either. So these lesions should be biopsied. I'd like to turn our attention now to neoadjuvant chemotherapy, and by this we mean chemotherapy which is given prior to surgery. We know that this has no survival benefit. However, it can help the surgeon achieve clear margins, particularly with a large primary tumor or when there's invasion of the pectoral muscle or skin. There are ongoing studies looking at stage 2 disease as well, and this can include patients who have a small primary tumor but a metastatic axillary lymph node. And we know that response is an early predictor of overall prognosis. Intriguingly, and this is something that really hasn't yet reached its full potential, there is the opportunity to change chemotherapy regimens if there's no response to the first cycle of treatment. And this is something that I think we'll see a lot more progress in the coming years. If we're going to talk about the role of imaging in neoadjuvant chemotherapy, we certainly need to have accurate measures of the pre- and post-treatment tumor size and full extent. Clearly, we want to place clips at the time of initial biopsy because the tumor can actually melt away with treatment. And in this situation, it is important to stage the axilla as well as look at for systemic metastasis prior to treatment. The staging of the axilla can be done either with a sentinel node biopsy or with extensive imaging. In this situation, size determination has been looked at with mammography, ultrasound, and MRI is much more accurate than either mammography or ultrasound. PET has been looked at to assess response to neoadjuvant, and this is using whole-body PET imaging. As early as 1993, Rich Wall and colleagues showed that they saw a decrease in quantitative FDG uptake in the tumor within as little as 8 days after the initial treatment. This is very intriguing. We looked at the size of the cancers on PEM versus pathology in our study of 388 women. In the subset of 153 who had a solitary cancer with less than 10% DCIS, we found the correlation coefficient with the final pathologic size of the tumor was better for MRI at 0.81, but it was still good for PEM at 0.55. And we did not include patients with extensive DCIS because it is often difficult to size DCIS. And here are just some examples of using PEM to look at neoadjuvant chemotherapy response. This patient had a known cancer in the right breast, which you can see here, as well as uptake in a metastatic node and a second focus. But she also had unsuspected contralateral disease. And here, after 5 cycles of chemotherapy, you can see very good response on the right side. But interestingly, her left breast cancer did not respond well to her particular treatment. This is a very nice example of a patient who had more extensive disease. You can see mammographically as this palpable asymmetry. And on PEM, in her case, she had sequential PEM imaging done first just before treatment. Very intense uptake in this irregular mass known to be the cancer. Even as little as day 7 after the treatment, you could see quantitatively and qualitatively marked decrease in the FDG uptake within her cancer, and this further decreased by day 14. And I think this is a very intriguing early result, but we certainly expect that PEM will have a role to play in monitoring response to neoadjuvant chemotherapy. In conclusion, we now know from multi-center experience that PEM is an acceptable alternative to MRI for staging local extensive breast cancer. It's certainly well tolerated by patients and particularly can be used in women who are intolerant of an MRI. We know that PEM-guided biopsy has been validated. We have standardized interpretive criteria. PEM has been shown to be reproducibly interpreted as well with high specificity of PEM findings. And FDG-avid lesions are likely to be malignant with a high PPV of biopsy, such that use of SPIRAD-3 is discouraged. At this time, PEM is reimbursed in general, although you need to check with your local carrier for local extent of disease and preoperative staging, as well as response to neoadjuvant chemotherapy and suspected recurrence. Importantly, PEM can be performed the same day as PET-CT with the same dose. However, again, this may not be covered. It would be important to check with your local carrier, and this is an evolving area because I think it's very exciting to potentially do both using the same dose of radiotracer. It would be much more convenient for the patient. And here are just some references that detail the findings that I've talked about today. These are non-overlapping series that have recently been published online and will soon be coming in print. Thank you for your attention.